Number 51. A 15-year-old female was struck by a small car while riding her bicycle. She was wearing a helmet and was thrown to the ground, striking her head. In addition to managing problems associated with airway breathing and circulation, it is most important for you to A. Inspect the helmet for cracks, B. Perform a detailed exam, C. Obtain baseline vital signs, or D. Fully immobilize her spine. D. Now that you've got airway breathing and circulation covered, you want to go ahead and get her immobilized. So A, inspect the helmet for cracks is not really paying attention to your patient. It helps you understand the situation a little bit better, but when there's options that actually deal with patient care, those are the ones you should choose. And performing a detailed exam just doesn't need to happen before immobilizing her spine. Number 52. A 69-year-old female, I actually decided we're not going to go over this one. I can read it if you want, but the whole question hinges on you knowing what Inderal does as an action for the patient, and so it's really not worth it. So the answer here would be C if you feel like marking it down, but you really don't have to. You're not going to get a question like this. Ignore 52. 53. During your initial assessment of a 19-year-old unconscious male who experienced severe head trauma, you note that his respirations are rapid, irregular, and shallow. He has bloody secretions draining from his mouth and nose. You should A. Assist his ventilations with the BVM device, B. Suction his oropharynx for up to 15 seconds, C. Immobilize his spine and transport at once, or D. Pack his nostrils to stop the drainage of blood. B is the best answer. Remember, when you're dealing with a patient, you want to make sure you get those ABCs taken care of pretty much right up at the top, and you can't get his airway properly going until you suction because he's got those bloody secretions. Now, just so I'm clear, I want to make sure that I'm explaining this well. You would want to immobilize his spine, potentially. We don't know what kind of trauma this was, but in a trauma situation, when you want to immobilize the spine, the best way to answer questions, if it seems like there's too many things kind of that all should be happening at the same time, is think about what do you do when you were testing. So when you hear that somebody might have had spinal compromise, what is the very first thing you do? Like literally immediately. Okay, BSI, sorry. And then what else? Hold C-spine. Yeah, manual stabilization. Okay, manual stabilization comes first. When you're doing this in a real scenario, manual stabilization has to be there, and then you drop into your ABCs. You'd get rid of your life-threatening stuff, and then you go back and do full immobilization. So if you have a question where it's a trauma question, and the choice, like it's clear that he needs C-spine and like spinal precautions, and you have a choice between your ABCs and the spine stuff, if it says full spinal immobilization, it needs to happen, but not before ABCs. Manual stabilization needs to happen first, then, ABCs, life-threatening stuff like that, and then all the other spine precautions. Does that make sense? I know it doesn't really fit with this question, but that was something I was talking about with Randy the other day, and I wanted to make sure that was clear, that for question's sake, that's how you would order things. Does that work? Make sense for y'all? Okay. So the answer to this one was B. My explanation didn't really matter with this question. Number 54. A 30-year-old male experienced closed head trauma when he crashed. Oh, this one fits perfectly. When he crashed his motorcycle. He was not wearing a helmet. As you approach the patient, you can hear snoring respirations and can see blood draining from his mouth. You should A. Begin ventilatory assistance with a BVM and 100% oxygen. B. Immediately suction the patient's mouth and open his airway. C. Manually stabilize his head and perform a jaw thrust maneuver. Or D. Apply 100% oxygen and then perform a rapid trauma assessment. Yeah, so like I just essentially, all that explanation that I gave you fits perfectly with this. Manual stabilization comes first. You might be like inclined to think that the answer is supposed to be B because you got that airway breathing stuff going on right away, but manual stabilization first, and then it also specifically says jaw thrust maneuver, which is accurate here, so it's nice to have that specific answer. That's another sign that it's the correct one. Okay, number 55. While en route to a major motor vehicle crash, an on-scene police officer advises you that a 7-year-old male who is riding in the front seat is involved. He further states that the child was only wearing a lap belt and that the airbag deployed. On the basis of this information, you should be most suspicious that the child has experienced A, open abdominal trauma, B, neck and facial injuries, C, blunt trauma to the head, or D, lower extremity fractures. So A, open abdominal trauma. How likely is that? Not particularly in this case. You've got a motor vehicle crash, you've got an airbag that deployed on a small child, but you're not likely to see any open abdominal injuries, not based on what it's telling you. B, neck and facial injuries. So who is supposed to be sitting in the front seat of a car? I think it's 12 or up. At any rate, it's meant to be like an adult-sized person. Is a 7-year-old male going to fit the seat properly according to how the manufacturers design it? No. Which means those airbags, where are airbags supposed to hit adults? In your chest. So a child who's shorter, where's the airbag probably going to hit? In the face. Yeah. Head, neck, face, all that stuff. So not only the actual trauma from like a direct hit, those things go so fast, you guys, there's a lot of force behind them. It's very, very quick, but it's very, very, very forceful. So that's a lot of instant force to the face and neck and the head injury area. You're also potentially going to have some chemical burns from the powder that is involved in the whole send-off, whatever, deployment of the airbag. So B is a really good answer because it answers all of those options that you've got. Blunt trauma to the head? Not necessarily. It's not that it's a bad answer, but it's maybe not as precise as the whole neck and facial thing. When I think blunt trauma to the head, I think of like something hitting the head, not so much this. And when you have a choice like neck and facial injuries that is very specific to the situation, it's going to be the better one between those two. And then lower extremity fractures doesn't really fit what we're talking about. It's not that you wouldn't see it, but they're asking specifically, what is the airbag going to do to this child? And neck and face trauma, or neck and face injuries fit that the best. Who would you be actually very likely to see lower extremity fractures in a motor vehicle crash like this? Okay, driver. Really any adult, especially any adult in the front seat, especially any adult in the front seat with like really long legs. Really any adult in the front seat in general, because what's going to hit? Like something's going to impact the dashboard. What is going to hit? What part of your body? Your knees are going to hit the dashboard as it crumples forward. You see a lot of femur fractures in adults in motor vehicle collisions because of this, because that impact on the front of the knee is enough to shatter somewhere on your femur. You may also see lower down stuff, but that femur injury is really, really distinctive, and you should just be aware. I don't know, you might have a question that kind of has that in there. You might have questions like the same basic setup, but what should you most suspect? Femur fractures or bilateral femur fractures, be aware that those might happen. That's pretty common. 56. You arrive at the scene of a major motor vehicle crash. The patient, a 50-year-old female, was removed from her vehicle prior to your arrival. Bystanders who removed her state that she was not wearing a seatbelt. The patient is unconscious, tachycardic, and diaphoretic. Your rapid trauma assessment reveals bilaterally equal breath sounds, a midline trachea, and collapsed jugular veins. You should be most suspicious that this patient has experienced A, massive hemothorax, B, tension pneumothorax, C, pericardial tamponade, or D, laceration of the aorta. So, what is a massive hemothorax? Yeah, blood in the thorax, internal bleeding in the thoracic cavity. Okay? Tension pneumothorax. We've talked about that. Yeah, so air building up within the thoracic cavity. Specifically, we're kind of thinking about something poking in trauma from the outside. Remember we talked about how in a tension pneumothorax, the air is rushing out of the lung and it has nowhere else to go, and it's building up inside, and we talked about like putting your hand on the one-way valve, all that stuff. I know I explained it badly in the last one, but hopefully you at least remember what it is. Pericardial tamponade. Anybody remember this one? Yes, good job. Pericardial tamponade is when the sac that surrounds the heart is filling up with fluid, blood. We're not, it's not always one thing versus another. But that sac, the membrane that surrounds the heart is filling up. That's putting pressure on the heart, okay? And then laceration of the aorta. It is what it sounds like. The aorta, which carries the vast majority of your blood at any given time, lacerated, cut open, big problem. Bleeding out quickly inside. Okay, based on that, does anyone have an idea what the answer is? Okay, so we'll keep talking about them. It's okay, I just wanted to see. We talked about massive hemothorax. What are going to be some signs? If we're thinking that it's a hemothorax, what are the signs we would see externally on this patient? Remember, blood filling up inside the thoracic cavity, filling the space where normally heart and lungs would be full. You wouldn't necessarily see you'd say a rise in blood pressure?
Or like your blood pressure change.
You'd be more really with most of these, you'd be more likely to see, with that one specifically, more likely to see a drop in blood pressure because you're bleeding internally. So you're bleeding out in some way. You'd see hypotension. Let's see. If you have a massive hemothorax, what would you expect to see in the trachea? It would be moved over. Yes. Just like with, there's several conditions that can cause that, but essentially you've got blood filling up in the thoracic cavity where it shouldn't be, putting pressure on all the stuff that is actually supposed to be there. And wherever that bleed is, it's going to be pushing the other stuff away. So if you've got a bleed on this side, for example, on the right side, something got messed up, and you're bleeding, the blood is filling up over here and pushing everything over. And part of what it's pushing over are your lungs, which are attached to your bronchi, which are attached to your trachea. So the whole assembly is shifting. And you would see a trachea that wasn't midline. Now, your patient has a midline trachea. Do you think it's likely that she has a massive hemothorax? Okay. Small hemothorax? Maybe. I mean, that's one of those things. You don't see that sign until it's really, really big. But they're telling us right here it is really big. It's massive. So you're going to assume that that can't be the answer because her trachea is midline. What about B, tension pneumothorax? What do you see in a patient who has one of these? Definitely not bilateral equal breath sounds. Yeah. Also, what do we know about the trachea in this case? Probably also pushing over, right? For the same reason that the blood would cause it to push over, a lot of air building up inside the chest would also cause it to push over. So both the massive hemothorax and the tension pneumothorax are not likely based on those signs. Pericardial tamponade, fluid around the heart, pressing in on the heart, putting a lot of pressure on the heart. There is something called Beck's triad that are 3 specific signs that we associate with pericardial tamponade. Anybody know what they are? Anybody want to guess? JVD is one of them. Why? For the same reason that it's a sign in congestive heart failure. There's pressure on that heart. It can't beat well. It's essentially like it's weakened because of that pressure pushing externally on the heart. So it can't push well, and that means the blood is backing up everywhere because it's not properly pushing through the heart like it's supposed to. So JVD, hypotension, stroke volume's going down, so you're definitely having hypotension. Y'all remember that from last year? Sort of? You should remember it now. And then muffled heart sounds. Because that fluid is around the heart, if you're trying to listen to it, it's going to sound muffled, like you're listening to it through water or fluid or something. Just like how hearing is muffled underwater, the heart's going to sound muffled under a lot of liquid. So, do you think it's likely that this patient has pericardial tamponade? No, because of that JVD. So, your patient has a laceration of the aorta. That's the only answer choice left. Now, what supports this idea that she has a laceration of the aorta? Tachycardic, okay, so we've got some shock signs, right? Unconscious, blood loss, tachycardic, diaphoretic, those are signs of shock. Bilaterally equal breath sounds, that's just a negative finding. It means we know that it was the pneumothorax. Midline trachea, again, we just know that meant that the other stuff wasn't there. Collapsed jugular veins, what might that indicate? Shock and, yeah, low blood pressure. She's bleeding out into her body. Her aorta is lacerated. So that blood, which would normally be filling up those, isn't there. So, 56 is D, laceration of the aorta. Y'all need to be looking up this stuff. If you don't remember what pericardial tamponade is, you don't remember Beck's triad, you need to look that stuff up. Make sure you understand that sort of thing, because that is definitely one of those conditions they're going to expect you to understand on the test. They're not going to give you leeway on that kind of thing. Okay, 57. Following a blunt injury to the head, a 22-year-old female is confused and complains of a severe headache and nausea. On the basis of these signs and symptoms, you should be most concerned with the possibility of A, spinal cord injury, B, airway compromise, C, intracranial bleeding, or D, a fracture of the skull. C, makes sense in this case. We've got that blunt injury. She now has altered mental status. The headache and the nausea are classic signs of intracranial pressure, which would be caused by the bleeding going on inside of her head. 58. You and your partner arrive at the scene where a truck has crashed into a small building, injuring 8 people. You immediately request additional ambulances and begin the triage process. The first patient that you triage is a young female who is unconscious and apneic. She has an open head injury and her pulse is weak and thready. You should A, assess the severity of her open head injury, B, place a red tag on her and continue triaging, C, begin ventilating her with a bag valve mask, or D, give her a low priority and continue triaging. So we talked about those triage levels. We talked about how red are the people that you can save. Life-threatening injuries, but they're things that you can work on without expending a huge amount of resources. Yellow is people who are injured, can't walk around, but not life-threatening. Again, think of like broken bones, things like that. Green is the walking wounded, people who can walk, have some degree of injury perhaps, but certainly nothing major. And then black are people who are either dead or what we said non-salvageable, as in they would require a huge amount of resources to hopefully make it, right? So in this case, your patient is unconscious and apneic with an open head injury, but she does have a pulse. Where does she fit on this continuum? Obviously, she's not green. She's not walking wounded. She's unconscious. She's not she's not yellow because of that whole open head injury thing, right? Apneic, yeah. So definitely not yellow or green. Between red and black, where would she be most appropriate? Black. Why?
Because it's like her pulse is like weak and dirty.
Really, the key thing here is that she's apneic. Okay, the only way she's going to stay alive is if somebody is sitting next to her for the next however long it takes, squeezing a bag to make her breathe every single time. She's not going to survive without somebody, one EMT, devoting every single bit of their attention to her. When you have a mass casualty incident with 8 people injured, she is not the person that you give one entire EMT all by herself to. She probably would really need more than one, but one just to keep her breathing. She'd be a black tag person because she can't survive, like not without a huge amount of resources expended on her. It sounds hard to put it that way, but you really want to put your resources where they can help the most number of people, help them the best. And she's just not a likely candidate. Her pulse isn't what disqualifies her. Unconsciousness isn't what disqualifies her. It's not even her open head injury. It's the fact that she's not breathing. The difference between respiratory distress, which would be a red, and respiratory arrest, as in she's not breathing anymore, and that puts her in the black category. So the answer here is D. Yeah, obviously. Give her a low priority, continue triaging. You would not begin ventilating her with a BVM unless you had a ton of resources, and you don't because you're there and nobody else is there and you need more ambulances. So she's not a first priority. We already said no to red, and then assessing the severity of her open head injury is more than you do in terms of a triage. Triage is just getting the basics, really basic levels going on, and you already gave her a level. 59. A 37-year-old male was pinned between the flatbed truck and a loading dock. On exam, you find bruising to the chest, distended neck veins, bilaterally diminished breath sounds, and bilateral scleral hemorrhaging. You should A, aggressively manage his airway, B, request a paramedic ambulance, C, perform a rapid trauma assessment, or D, suspect a severe hemopneumothorax. And so in this case, A would be the best answer, managing his airway, But it's something definitive that you can do. I'm honestly not a super fan of this question. I feel like requesting a paramedic ambulance would also be really, really, really important because I certainly can't deal with that myself. He does need a rapid trauma assessment, but it's definitely below those other two. And suspecting a severe hemopneumothorax, you might suspect a severe hemothorax because, okay, so he was pinned, you got bruising to the chest, bilaterally diminished breath sounds, meaning that he likely has a lot of pressure built up in his chest. So I would totally suspect some sort of internal bleeding. But again, it's relatively less. I went with A when I answered this question because airway is something that you guys know how to manage and you know that it's a first priority for any patient. So, 60. A construction worker fell approximately 30 feet. He is semi-conscious with rapid, shallow respirations. Further assessment reveals deformity to the thoracic region of his spine. His blood pressure is 70/50. His pulse is 66 beats per minute and weak, and his skin is warm and dry. In addition to spinal immobilization and rapid transport, the most appropriate treatment for this patient includes A. Oxygen via non-rebreathing mask, blankets for warmth, and elevation of his head. B. Assisted ventilation, thermal management, and elevation of the lower extremities. C. Oxygen via non-rebreathing mask, thermal management, and elevation of his legs. Or D. Assisted ventilation, preventing hyperthermia, and elevating his lower extremities. This is one of those where you just have to look at all the parts of each answer choice and decide which is the best overall way to manage. What is a decision we can make instantly about this guy? What does he need for sure? Assisted ventilation, right? Semi-conscious, rapid, shallow respirations. Again, we talked about how if somebody has shallow or reduced tidal volume, sometimes they put it, we know he needs assisted ventilations. So based on that, it's either B or D. And between B and D, which one is the better answer? So when we say thermal management, what does that mean? I mean, what does it mean in a practical sense? For this patient, what are you actually going to do? Treat for shock. And how do you do that? Putting a blanket on. You're trying to keep him warm, right? What is hyperthermia? A patient is too warm. Hyper versus hypo. So hyperthermia is what you get when you've been out in the sun too long or excessively out. Hypothermia is what you get when you've been out in the cold too long, right? Does this patient need you to prevent hyperthermia by putting cold packs on him, or does he need a blanket? A blanket. So thermal management is what makes sense. He's clearly in shock, super low blood pressure. This is a classic sign of, gosh, I forget what it's called, but I think it's called neurogenic shock. It's where the nerves have been messed up by this spinal injury, and they're not sending the proper signs down to the lower half of his body to constrict blood vessels appropriately, so that his skin is warm and dry. That's a classic sign. His blood pressure being through the floor is another classic sign, because all these blood vessels in his legs, everything below the injury is fully dilated instead of being regulated appropriately to dilate and constrict as necessary by the body. So the answer would definitely be B in this case.